Hello, I'm Jessica Keane. I'm a pharmacist by background and I'm currently the pharmacy lead at the NHS North West Genomic Medicine Service Alliance. Thank you for watching this presentation on genomic medicine and pharmacy practice. The aim of this presentation is primarily to raise awareness among pharmacy teams in the northwest of England about the importance of genomic medicine to our practice and how improving our understanding of genomics can result in better care for our patients. In this talk, we're going to discuss some of the terms and concepts used in genomics, understand a bit more about genomic variation, identify how the metabolism of medicines and other biochemical responses can be affected by pharmacogenes, discuss the existing and potential roles and responsibilities of pharmacy professionals in genomic medicine, and look at some supporting resources. Before we start, you might not be sure whether genomics is really relevant for you yet. Perhaps you're interested but think genomics still sounds quite futuristic. But no, genomics is already being used in practice throughout the NHS to support with treatment selection and medicines optimisation. More importantly, it is in the NHS genomic strategy to accelerate the use of genomics to support personalised medicine in the next 1 to 3 years. So now is the time to get ready so that you have the knowledge when testing has become mainstream. Perhaps you haven't seen the impact where you work yet. This might be true right now, but during the course of this presentation, I'll be telling you about 2 different NICE appraisals relating to pharmacogenetic testing technologies, one of which had an early value assessment in 2023 and another expected later in 2024. These technologies test for genetic changes that impact aminoglycosides and clopidogrel, 2 incredibly common drugs prescribed daily across the NHS, and there will be more on the way, so pharmacogenomics is becoming truly mainstream. You might not think it's something that will impact on your role. However, there is a study actively recruiting patients at GP practices here in the Northwest already that tests patients for common genetic changes in genes that are involved in how the body handles drugs. What this means is that if your role involves patients or medicines, in the coming months and years, you're increasingly likely to come across patients who already have information about their pharmacogenetic profile and will need to be able to understand what that means for them, their current and future treatments, and potentially support the wider MDT with the treatment decisions affected by this genetic variation. Finally, you may not want to be a genomic specialist, and that's understandable. However, genomics is now included in the standards for foundation pharmacists, so there is a minimum standard that is expected of all newly qualified pharmacy colleagues. Genomics is not just for specialists. Although it's not yet been included in the standards for pharmacy technicians, it's clear that in order to support patients with their medicines, it's vital that all pharmacy staff have a basic understanding of how a person's genetic variation can impact on their medical treatment. The other thing to say is that as genomic technology advances and becomes more mainstream, there is a real need to develop genomic medicine as a specialty for pharmacy, so there's a huge opportunity there for people who are interested to become leaders in this area. And so first, I want to start with a story. This is a real patient story. Her name's Jane and she's given me permission to talk about her case, but it's a story that might be familiar to some people. When Jane was 19, she had epilepsy and was well controlled on sodium valproate. This is a few years ago now, and so at that time, it wasn't standard practice for women of childbearing age to be converted to alternative anti-epileptics, and so Jane was switched to carbamazepine and her valproate is being titrated. Within a couple of days of starting this new medicine, she started to develop a mild itch in her arms, which was progressing day by day. So she went back to her GP, who diagnosed that it was a reaction to her washing powder. However, within a week, she was sick in bed with a sore throat and flu symptoms and a rash that just wasn't resolving. Later that evening, she collapsed and had to be admitted to A&E, where she had more than 5% skin detachment, was developing organ failure. What had actually happened is that she developed Stevens-Johnson syndrome. This is one of a range of syndromes, including toxic epidermal necrolysis, known as SCARS, severe cutaneous adverse reactions. After a 3-week stay on the intensive care unit, involving lots of supportive management, fluids, electrolytes, antimicrobials, and wound management, she was finally able to be discharged. So what was the cause? Well, it was Stevens-Johnson syndrome induced by the carbamazepine, and the most important aspect of her management was to remove the causative drug, which was luckily identified quickly by the doctor working on the ward. So why is all of this important in a talk about genomic medicine? Well, that's because there are known genetic variants which predispose people to experiencing these types of adverse drug reactions. What this means is that if we can test for them up front before we start a medicine, then if we find a person has a certain genotype, we can use this information to inform medicine selection and possibly choose an alternative agent, maybe tweak the dose or alter the monitoring they might need. Many of you may be aware, since it's in the BNF, that the HLA-B *1502 genetic variant, which is found in about 10% of Han Chinese and Thai origin populations, is associated with the risk of Stevens-Johnson syndrome in patients treated with carbamazepine. It's also found in some other Asian populations, but is very rare in European and African populations. You may also know that as a result of this, an MHRA alert came out in 2008 recommended preemptive screening for this particular genetic variant in people of Chinese or Thai origin before starting carbamazepine, due to the severe risk of Stevens-Johnson syndrome if the *1502 variant is identified. And so it's really important that patients in these groups are referred for screening prior to starting. There are other HLA variants, like HLA-A *3101, which are associated with higher risk of carbamazepine-induced cutaneous reactions in other populations. They're seen in something like 2 to 5% of European populations and 10% of Japanese. However, preemptive screening for this allele is not currently routinely offered because there's not as much evidence linking them. However, if a patient is known to have these types of variants, then we can make a risk-benefit decision around what the alternative treatments might be or the risk of having this reaction with the carbamazepine. So there are a number of different drivers as to why pharmacy professionals need to know about genomics. Really, you could say at the minute there's a genomic revolution going on. When the Human Genome Project first completed in 2003, it actually took 13 years and cost over £2 billion to sequence one human genome. Since the 100,000 Genomes Project completed in 2018, we can now sequence a genome in about a day, and it costs less than £600. Genome UK document provides a strategy to create the most advanced genomic healthcare system in the world, based on diagnosis, personalised medicine, prevention and research. And all of these huge documents on this slide outline the use of genomics in routine healthcare and how it applies to pharmacy practice. You may be familiar with things like the NHS long-term plan, which talks about how the NHS needs to take advantage of advances in precision medicine and outlines a role for pharmacy in relation to best value medicines. You might be less familiar with documents like Genome UK or the NHS Genomic Medicine Strategy, but they do highlight the importance of incorporating genomics into routine healthcare. Where you will be more familiar with are probably the GPHC standards for foundation pharmacists and the RPS prescribing competency framework, both of which talk about the need to apply the principles of clinical therapeutics and genomics to make effective use of medicines for people. We hear these two words used, often interchangeably, but what's the difference between genomics and genetics? The human genome, or that of any organism, is the full DNA sequence, your complete set of genetic information. The genome therefore includes all genetic information, which is both coding DNA, or genes, and non-coding DNA. There are about 21,000 genes in the human genome, but this accounts for only 1 to 2% of the genome. That is, 98% is non-coding. Genomics is the study of all of this information, whereas genetics describes the study of single genes and their function. Following on from this, pharmacogenetics is the impact of a single gene on the interactions between one specific medicine or group of medicines and the body, whereas pharmacogenomics can be used to describe the study of how a patient's genome can influence how they respond to medicines more generally. Genomic variations are known as polymorphisms. It's an older term. Genomic variations describe the differences in sequences of DNA between two individuals, and you can see that we are hugely similar, but there are also common genetic variations which are essential and contribute to biological and visual differences between us. Genomic variation can also directly cause rare health conditions or result in variable risk of developing common health problems, differences in how we respond to medicines, or have no effect at all. And variations can occur in different ways. They may be changes in a single DNA base, across one gene or many genes, or in large parts of chromosomes. There are also different types of genetic variation. Germline variants are inherited from parents and exist in an individual's DNA throughout their lifetime. They might be associated with development of certain conditions. For example, variants in the CFTR gene lead to cystic fibrosis. But patients with genomic variations do not always develop conditions associated with the variant. For example, BRCA variants are associated with increased risk of some cancers, but it's not 100% predictive. Germline variants can also be seen in genes for things like drug metabolizing enzymes or transporters. They may have no effect whatsoever on the patient's life unless they're exposed to a relevant drug. This could be in genes that code for enzymes involved in the pharmacokinetics or pharmacodynamics of medicines, or in HLA genes that are involved with immune-mediated adverse drug reactions. External factors like the environment or infections can also activate genomic variations, leading to conditions, for example, the development of cancer or diabetes. Somatic variants, on the other hand, tend to accumulate within subpopulations of cells in the body and are acquired over a lifetime. They're not heritable, and genetic changes in cancer cells are the most common example we see of somatic variation. There's also lots of research going on into variants we don't yet fully understand. So on this slide, we can see 5 different babies, each of which is presented with neonatal diabetes. Changes in more than 25 different genes can be associated with this condition. New genomic sequencing technology has enabled us to find 5 new genetic subtypes and provides a single test that gives a diagnosis for around 80% of patients. The genetic subtype predicts the clinical course and whether the diabetes will remit, whether other organs will be affected, the risk that future siblings will also develop neonatal diabetes, and the most appropriate treatment to achieve the best clinical outcome, which, as you can see, varies widely depending on the genetic diagnosis. So we've talked a lot about how a person's DNA or the genomic information can be used to personalise their treatment. I do want to reflect here that we can also use other sources of genomic information. For example, we can exploit the genetic differences seen in the genome of a person's cancer to target their treatment. And for people with an infection, we can also sequence the infective organism. This helps us understand more about the organism, to track disease outbreaks, and to look for patterns of antimicrobial resistance. So how is all of this relevant to pharmacy? Well, genomics can enable personalised medicine from novel therapeutics right through to optimising existing treatments. For example, gene therapies can use new technology, delivering tailor-made genetic material into a patient's cells to treat their condition. For example, CAR T-cell therapies for things like B-cell lymphoma and leukemia, or Libmeldy for metachromatic leukodystrophy. New targeted treatments can also be based on our increased understanding of genomic basis for disease. So, the classification of cancer by genomic variants found in the tumour cells or in circulating tumour DNA has led to targeted and histology-independent treatments in some cases. In cystic fibrosis, the drug lumacaftor-ivacaftor targets changes in the CFTR gene. Treatment can also be based on precision diagnostics. This is how we can stratify patients. For example, people with monogenic forms of diabetes have specific treatments that differed from the standard care given for type 1 and type 2 diabetes. This makes the appropriate diagnosis essential. Also, patients with conditions like familial hypercholesterolemia might require different lipid optimization. We can also use genomics to predict drug resistance. If you think about COVID-19 treatments, viral sequencing impacts eligibility for treatment based on whether the drugs are effective for people with Omicron or Delta variants. Molecular profiling of cancers, serial sampling and genomic testing of tumours can detect early resistance to treatment. And as mentioned before, pathogen genomics can predict antimicrobial resistance. For example, we use whole genome sequencing routinely to identify different strains of tuberculosis and detect drug resistance. And finally, pharmacogenomics can guide treatment decisions and dosing, using genomic data to predict drug response. Pharmacogenomics can improve drug effectiveness and/or reduce the risk of side effects. For example, in abacavir, genetic testing for the HLA-B5701 variant can be used to prevent people having severe skin reactions with abacavir commonly used to treat HIV. We can also use pharmacogenetic testing to tailor dosing. For example, CYP2C9 testing for siponimod, TPMT testing for thiopurines. All this type of genotyping guides the dosing of the relevant drug based on whether the patient is identified as having a normal or altered metabolizer phenotype. Medicines are only effective between 30 and 60% of the time, and there are a whole host of reasons for this, some of which are listed on the slide here. However, one important reason for this is related to common genomic variation. If we followed the standard approach, patients tend to be prescribed a specific medicine for the condition based on local or national guidance, and this is often at a fixed dose, something often referred to as a one-size-fits-all approach. Their genetic variation affects whether and how they respond to this medicine, and they subsequently may need to come back to their prescriber to have their dose increased, decreased, or even changed onto a different treatment until they find the right dose of the right medicine for them. Since genomic medicine is stable throughout our lifetime, this enables a pharmacogenomic approach where we could actually preemptively test for a number of common changes and use this information up front, improving the chance of getting the patient onto the right medicine and dose for them. Some other causes of variation in response to medicines, like poor adherence, may be downstream effects of genomic variation in people who experience adverse effects. This is not to say that pharmacogenomic testing will guarantee medicine's effectiveness, but to highlight that it is a valuable tool to support medicine's optimization. So, why would we want to implement pharmacogenomics in the NHS? First of all, this type of variation is incredibly common. Almost the entire population will have at least one pharmacogenetic variant which will impact their response to medicines. We also know that prescribing is the single most common intervention in the NHS. In practice, a 2021 study calculated that based on the prevalence of pharmacogenetic variation in the population, around 1 in 5 of all new prescriptions in the UK primary care for medicines with pharmacogenetic guidance are estimated to have a drug-gene interaction. We also know that adverse drug reactions are expensive, so there's huge potential for pharmacogenomics to start reducing this impact. So you can see why, if it's possible to test for these types of changes, healthcare professionals and patients will be interested to know the results before starting a new medicine. Now I'm going to give you a few examples of how pharmacogenomics can be used in clinical practice. Aminoglycoside antibiotics like gentamicin and amikacin are commonly used, and it's well known that their use can result in hearing loss. In most people, this will only happen after extended courses or at very high doses. However, there is evidence of an association between a mitochondrial genetic variation with an increased risk of this ototoxicity after even single doses of aminoglycosides. The most common of these is a variation in a gene called RNR1, where there is a change in a single nucleotide, and this is present in about 1 in 500 individuals. As you can see in the central image on this slide, the way that aminoglycosides work is that they usually attack the 16S RNA subunit of the bacterial cell to have their bactericidal effect. In the majority of people, as seen on the left diagram, the aminoglycoside would not interact with the mitochondrial ribosomal subunit. However, in the 1 in 500 patients with a specific genetic variant, this causes a change to the binding site of the mitochondrial subunit, which means the aminoglycoside can bind and cause damage to the cells, particularly the hair cells of the inner ear, causing hearing loss. Genetic testing is commissioned through the National Genomic Test Directory and available from the Northwest Genomic Lab Hub on Form R65. It should be considered especially in patients with predisposition to gram-negative infections or who require recurrent or long-term treatment with aminoglycosides, but it's important not to delay urgent treatment in order to test. It's important to note that due to the extended turnaround time in the lab for the commission test, testing should only be requested for individuals who are likely to need aminoglycoside antibiotics in future, and definitely not to be done where urgent treatment is required. However, since aminoglycosides are primarily given in the acute setting and first line for neonatal sepsis, a team here in Manchester set about establishing the PALO study to try and address the issue of turnaround time by investigating point-of-care genetic testing for the neonatal population. The study has been published a couple of years ago now, so you can read more if you're interested, but what they were able to do is deliver a test result in around 25 minutes. What this does is it means it enables testing in an acute setting within the 1 hour time frame needed to start antibiotic treatment for a bacterial infection. In the study, from the 751 babies recruited, they found 3 with the particular variant who were able to be offered a safe alternative antibiotic. A nice early value assessment came out in March 2023, and this was positive, suggesting that this is a cost-effective genotyping approach. Work is still ongoing as part of this early value assessment to build the evidence base for the use of this test before it is rolled out to neonatal units across the country. Another example is with clopidogrel, which is a commonly prescribed antiplatelet. It also happens to be a prodrug, activated by two-stage oxidation to the active metabolite, which then inhibits platelet activation and aggregation. Many cytochrome P450 enzymes are involved in the metabolism of clopidogrel. However, a person's CYP2C19 status, that is, whether or not they have a normal or altered CYP2C19 phenotype, has been found to be associated with the increased risk of cardiovascular events in people who are taking clopidogrel. If we agree that finding out someone's CYP2C19 metabolizer phenotype before prescribing them clopidogrel and sending off a sample to the lab is a good thing to do, then the next challenge comes when we get the result. What the bioinformatician in the Genomic lab sees is highlighted in this first box on the left. It's fair to say that this would be almost useless to the average prescriber if we shared the result with them in this manner. What's really important in this scenario is that we present the results of the pharmacogenetic test to prescribers and clinicians in a clinically relevant format that they can actually use. In pharmacogenomics, this is done by assigning functional status to commonly found genetic variants and assigning them something called a star allele. The combination of star alleles that someone possesses for a given pharmacogene is known as their diplotype, and based on this we can assign a phenotype such as intermediate or poor metabolizer. Since the vast majority of people won't know off the top of their heads what the appropriate action is when prescribing a particular medicine for someone with a given phenotype, a crucial part of reporting pharmacogenetic results is the clinical interpretation and presentation of pharmacogenetic guidance relevant to the drug being prescribed. This type of guidance is available from an organisation called CPIC, the Clinical Pharmacogenomics Implementation Consortium, who produce peer-reviewed guidelines for drug-gene pairs. So, for example, for patients with acute coronary syndrome having a PCI, the guidance is that intermediate metabolizers are at increased risk of major secondary cardiovascular events compared with normal metabolizers, so the advice is to prescribe an alternative antiplatelet. There are differing levels of evidence on the impact of these phenotypes on clinical outcome, and with that, there are different strengths of guidance based on the clinical indication for the prescription. I'd just like to highlight here, this isn't something that's futuristic. NICE are currently developing guidelines around the implementation of CYP2C19 genotyping prior to prescribing clopidogrel for patients with stroke. Final guidance on that is expected to be published in July 2024. But actually, clopidogrel genotyping is already a reality within the acute stroke unit in NHS Tayside in Scotland, where the stroke pharmacist requests CYP2C19 genotyping from their genetic lab for their patients and then interprets the pharmacogenetic report along with the individual patient characteristics to optimize their antiplatelet treatment. And it's not just medicines that are initiated in secondary care. Really common medicines like codeine are also implicated. You probably know that codeine is an inactive prodrug, which requires conversion by CYP2D6 to the active metabolite morphine in order to exert its analgesic effect. And so, a range of people might benefit from CYP2D6 testing, including anyone requiring pain control, since poor metabolizers will not metabolize the necessary amount of codeine to morphine to have effective analgesia, but also ultra-rapid metabolizers who might experience opiate toxicity due to excessive morphine levels. For breastfeeding mothers, an ultra-rapid metabolizer might have unsafe levels of morphine in their breast milk, which then goes on to affect the infant. And in fact, based on this drug-gene interaction, codeine is contraindicated in CYP2D6 ultra-rapid metabolizers of any age. There's also a drug safety update from MHRA, which, although it is focused on limiting codeine use in children for many reasons, does identify the risk for CYP2D6 ultra-rapid metabolizers. The current direction of travel for pharmacogenetic testing is towards the use of truly preemptive pharmacogenomic panel testing, where multiple gene changes are tested for at once, at a relevant time point in a patient's lifetime. These results would then need to be available in a clinically relevant time frame and in a clinically relevant format to the relevant healthcare professional, be that when starting a new medicine in primary care, when buying medicines over the counter in a community pharmacy, or in the acute setting in secondary care throughout their lifetime. It's important also that we give consideration to patient ownership of their own pharmacogenetic data and how these results can be accessed and presented in a way that is useful for individuals. Through the Northwest GMSA-led Progress Programme, we are seeking to better understand how this kind of service can be rolled out across the NHS. You can learn more about that work on our Northwest GMSA website. Before I finish, I'd like to touch on the topic of privately bought or direct-to-consumer genomic tests. The advice here is to exercise caution when asked to offer or provide clinical expertise about the results of DTC genomic testing. There is guidance available from the Royal College of GPs and British Society for Genetic Medicine from 2019, shown on this screen. What this recommends to consider is the risk of false negatives or positives, whether the lab's accredited, whether the right technology was used to test for this variant, and whether genomic testing was clinically indicated, or if referral through NHS pathways would be an option. And when it comes to pharmacogenomics, we also need to think, are there clinical guidelines for this drug-gene pair, and do we have our own professional competence to deal with this? The existing guidelines available don't specifically consider pharmacogenomic testing, but the same principles apply. Trusts should have their own governance in place, and if there are any queries related to this, please share them with the GMSA pharmacy team. Finally, it's been recognised that pharmacy is a core pillar required for the embedding of genomic medicine within the NHS, and each GMSA around the country has a dedicated pharmacy lead, who acts as a central contact for pharmacy teams in their region to support the use of genomic testing as part of routine care. We have a genomics pharmacy network here in the Northwest, which I would urge you to join if you're interested to help drive change in this area and to keep up to date with our regular newsletter. There's also a dedicated webpage on the GMSA website with links to useful resources and further learning, some of which I'll go through now. CPPE has got a wealth of resources targeted to the pharmacy workforce. They have two different packages. One is an Introduction to Genomics in Pharmacy e-learning package, and secondly, a recently launched Introduction to Person-Centered Consultation for Genomics. These resources are free for CPPE and all UK registered pharmacy workforce, and there's a small fee for non-members. The RPS also has a number of resources, including a webinar series and a number of professional statements around the role of pharmacy workforce in genomic medicine. The NHS England Genomics Education Programme also has a number of different resources available, and I'd encourage you to go to their website. Importantly, they have bite-sized learning and short blogs, right through to funding for NHS staff for formal qualifications and MSc modules, including one in pharmacogenomics and stratified medicine. We also now have a GNotes resource which is available and can be used to look at various topic-specific areas, including primary care and pharmacogenomics. To view all of these in one place, I'd encourage you to visit the Northwest GMSA website shown on here and see our education and training page, where you will see all of these resources listed. Another important resource to signpost to is the National Genomic Test Directory, which is like a formulary or a list of all the currently commissioned tests from NHS England. Pharmacogenomic tests are split between the rare and inherited disease and the cancer directories, but there are a whole range of other genomic tests which are linked to the prescribing of targeted medicines. So I think you'll agree there's a key role for pharmacy in advocating for the rational use of pharmacogenomic testing to support medicines optimization, both for individual patients and within whole cohorts of patients. You can see that pharmacy could be involved right through from offering a test through to guiding a result, using the results to guide management. Pharmacists have a clear role in interpreting pharmacogenomic reports and providing prescribing recommendations to other clinicians. Both pharmacists and pharmacy technicians are well placed to counsel patients on the benefits and limitations of pharmacogenomic testing, as well as the outcome to support with shared decision-making around treatments. Pharmacists can and should be leading on pharmacogenomics implementation and leading research and service evaluations, assessing the impact of changing practice on service and patient outcomes. Pharmacy staff can also act as champions for pharmacogenomics, supporting other healthcare professionals to embed pharmacogenomics within their clinical pathways. Thank you so much for joining me for this video, and I'm happy to be contacted if there are any further questions. Goodbye.